So hello everyone. So thank you so much for the coming to this session. My name is Kentaro Hayashira from Tokyo, Japan. The title of this session is How to Optimize TAVI Outcomes in Extreme Patient Anatomies that is quite relevant to our daily practice. The session objectives are to understand how to optimize TAVI outcomes in patients with small annular anatomy. We also need to learn how to achieve optimal valve implantation in patients with large annulus. We also need to learn to ensure optimal lifetime management of your younger TAVI patients. And I would like to introduce our team, Maurizio from Switzerland, on my left side as a spokesman. We also have distinguished discussant, Yohei from Japan, who is the course director of the PCR Tokyo Valve with me, and Dr. Rohan from Australia, and Dr. Simon from Hong Kong, and Dr. Juhan from Korea. So today we're going to have these three talks and followed some discussion. And I'd like to introduce the first speaker, Dr. Masanori Yamamoto from Toyohashi Heart Center, Japan. And today he's going to talk about how to treat the patient with small aortic annulus. So Masa, please start.
Okay. So thank you very much for inviting me. It's a privilege to have an opportunity to present here. Thank you. So here is my disclosure, and this is a case summary of patient background. Patient sex is female and relatively younger in our Asian cohort, 70 to 80 years old female. And the body characteristic is quite small. The body surface area is 1.36 centimeters square, and risk factor having atrial hypertension, DM type 2, and with comorbidity is coronary artery disease. And the clinical frailty scale is 3. That means not frail patients. So here is echocardiography and the coronary diastolic catheter. And obviously the aortic stenosis showing the mean pressure gradient at 44 with preserved ejection fraction is EF is 72.9. And coronary artery showing the significant stenosis with significant ischemia in the LCX artery. And here is an aortic valve complex measurement by CT scanning. It's quite small. The calculated annulus area is 277. That means smaller limited, even with those any kind of THVs. And perimeter is 61.7. And valsalva is ST junction is also quite small. It's a 26 and ST junction is 22 and 20. So here is a summary of my case presentation. The severe aortic stenosis, relatively younger, 70 to 80 years old range, and low surgical risk patients, and TF is suitable based on the CT scanning, and coronary height is 18 and left coronary artery is 13. So that's no risk of the coronary obstruction. And membrane septum calculated by CT is 3.9. And electrocardiogram before procedure showing the no bundle branch block right and left. But the very small body characteristics, body surface area 1.3, and annulus area is 277. So that is my presentation.
Thank you so much, Masa. Thank you so much, Masa, for your clear presentation. The patient is a lady, and in her 70s age, and low surgical risk, and with coronary artery disease. And she also had extremely small aortic annulus with the body surface area of 1.36. So Maurizio, I would like to ask you, because you're a cardiac surgeon, so how would you treat this patient in your center?
Yeah, thanks for your question. In our center, we would definitely, despite the challenge that you mentioned, we would definitely consider TAVR as a first option. Of course, it is from the number of low-risk surgical candidates, so you may consider also surgery. But small annuli is a challenge also for surgery. Yeah. Then the STJ is really calcific, so I mean, manipulation during surgery could increase the risk of stroke or ischemic events. Since the femoral access are okay, and since we have good option, let's say also for a small anatomy, we would definitely consider TAVI for this patient in my center.
Yep. If you treat this patient by surgery, maybe you need to do some annular dilatation or additional procedure. It could be a little bit the higher risk. So maybe I would like to ask Simon. So how would you treat this patient with the maybe TAVI device?
Yeah, so this is a TAVI candidate in our population, but the overall concern is more analysts that we may need to choose a smaller possible TAVI size.
Yep.
So we think about hemodynamics, but overall, this patient, overall the build is small. Taking into body surface area, this is really reflecting the population that we are treating.
Yep.
So the other thing that I would consider is whether if it's a perennial valve, I worry about sinus sequestration because of the small STJ and also future coronary access.
Yep.
So probably I would choose between stabilizing good hemodynamics without jeopardizing the overall anatomy, because not just the annulus, the STJ sinus are all very small.
Yeah, that is also important to consider lifetime management for this kind of patient. Maybe Yohei, so this patient had the coronary artery disease, so how would you choose the bioprosthesis for this patient?
Yeah, it's so interesting that Masa said this patient has an age of 70 to 80, because it quite depends whether if she's 70 years old or 80 years old, depends on the region based on the guideline and so on. But if we were considering TAVI for this patient, as he mentioned, the ST junction is quite calcified and narrow. So I would definitely avoid a balloon expandable platform for this patients. Considering the balance between the coronary access and avoiding conduction disturbance, I think for this specific case, I think both supra or intra-annular platform will perform well. I want to ask you, Masa, what is the volume of the calcium? We didn't see the calcified leaflets, so how heavy it is, and well, it also I think depends.
Sure, great.
Yeah.
So maybe I would like to ask Masa to continue your presentation.
Okay.
How you treat the patient.
Okay, thank you. So that the calcium volume is moderate, is 1,500. Okay, very standard calcium proliferation. So how to choose a THV for small anatomies? So I consider the valve performance, number one, is of course that means the mean pressure gradient or existence of PPM or PVL and pacemaker implantation after valve implantation. And if the patient has a coronary artery disease, it's very important to consider the future coronary access. And again, and the next step is a THV durability we need to consider, and to ensure the repeatability of the future TAVI procedure as much as possible in this procedure. So here is a start line to consider the valve hemodynamics. This is the data from Ocean TAVI registry in our Japanese internal data. So the rates of the severe PPM is surprisingly similar between the balloon expandable valve and the supraannular design, self-expandable valve. But the mean pressure gradient more than 20 is significantly higher if we choose the balloon expandable valve, comparing with the supraannular design. And that, in contrast, the prevalence of the mean PVL more than mild is significantly higher if we choose the supraannular self-expandable valve, comparing the balloon expandable valve. So finally, the results are quite same. The back-defined three device success is equal. Okay, so let's move on the balloon expandable valve versus intraannular design of intraannular self-expandable valve. Okay, left side panel showing the overall and PS matching cohorts concerning the PVL mild, the incidence of the mean pressure gradient more than 20, and incidence of the PPM. And focused on the area less than 430, that means a small anatomy, the situation is completely same. Better hemodynamics can be achieved with self-expandable valve design, but the rates of the PPM and pacemaker implantation is significantly higher if we choose a self-expandable valve design. And that is a great debate between the intraannular versus supraannular self-expandable valve. If we choose a supraannular self-expandable valve, we show the better hemodynamics in terms of the mean pressure gradient is lower, but the difference is only 0.9 millimeter mercury. That means the difference between the intraannular self-expandable valve and supraannular self-expandable valve, the difference is marginal in our cohort. And the rates of the severe PPM are quite similar, and the rates of the PVL more than mild are also similar. That is the start line. And so the conclusion is updated outcomes of the latest generation THV valves. The better hemodynamics can be achieved if we choose a self-expandable valve series. But the trade-off is a mean pressure, higher rates of the PVL and PMI. But PVL is truly higher in the self-expandable valve. We need to consider again. So the RCT clearly showing there is no significant difference in terms of the rates of the PVL mild. That is a great, we, in our ocean data, didn't include the calcium volume in the PS matching models. In our daily practice, we prefer to choose a self-expandable valve in case of particular very abundant excessive calcified proliferation cases in self-expandable valve. But we need to standardize and equal distributed calcium volume should be considered. And again, I would like to show the importance of the design of the bioprocesses. If we choose a supraannular design, self-expandable valve, the distal part is 23, but the west is 20. But intraannular design that called navitar is a distal part is 23, but outflow is also 23. And the difference is we focus on the 23 millimeter size of the THV. For example, this patient having a 277 millimeter square. So the competitor of the navitar 23 is not a 23 balloon expandable valve. Its competitor is 20 balloon expandable valve. And the competitor of the 23 intraannular design is supraannular design 23. And we focused on the 20 balloon expandable and 23 navitar valve. The results are quite same, but the better hemodynamics can be achieved if we choose a self-expandable valve. And that is a very interesting report that only submitting data. Ocean registry data, I reanalyzed, expanding more patients. Number of the patients is 144 versus 144 intraannular versus supraannular designs. Surprisingly, the mean pressure gradient is significantly lower in the intraannular designs. Because of the shape of the supraannular design, the waist is 20, so that the hemodynamics is a little bit reduced comparing with the intraannular designs. That result only focused on proved in the 23, not 26. Okay, that is the reason why I choose this case. So I choose the navitar intraannular self-expandable valve for this case. Predilatation is done, and appropriate position aiming to the 3 to 5 below the annulus, and no PVL was observed. And post-procedural findings, there is no significant PPM, and even moderate. The index to EOA is 1.54. The patient having a 277 millimeter square, but hemodynamics is excellent. Mean pressure gradient is 11, and no PVL was observed. And patient discharged earlier without a complete AV block. And of course, we have a lot of discussion. This diseases should be treated or not. But significant ischemic territory and a little bit dyspnea of effort after the TAVI procedures, I do stabilize these lesions. And unfortunately, the severe misalignment is occurred after the deployment of navitar valve. But the cannulation is very easy. It's possible to PCI after navitar implantation is very similar to the standard practice in our daily practice of the PCI. a successful PCI are performed. So, okay, so how to choose a THV for small anatomy? We consider the valve performance and coronary access. And THV durability, of course, we need the data, long-term data. And I would like to propose if we do choose the valve to achieve the commercial and coronary alignment is important in the future. Okay, thank you for your kind attention.
So thank you very much, Masa. It was quite striking data to see that the navigator did better than Evolut in the terms of the inpatient with small annulus, especially with 23 millimeter valve. And in this patient, you also achieved very good result. So what do you think is the potential reason why navigator demonstrated very good hemodynamic performance, even though it's interannular design?
Yeah, sure. As I told you, it's design of the cylinder type of the navigator valve is, the very interesting result. It's if the annulus perimeter is larger, the mean pressure gradient is decreasing, depending on the larger effective volume that can be achieved. So the design, not only the leaflet design, but also the stent frame design is so important to get the better hemodynamics. Because if we adopted the same analysis, 26 versus 25, is a supraannular design is significantly having good valve hemodynamics comparing with the 23 millimeter valves. That is the reason why the navigator valve has good hemodynamics, particularly in 23.
Thank you so much, Masa. So,
I one question is sorry. So I think it's small annulus is older is not same. So some is circular the small annulus, some is very elliptical the small annulus. So your case is very elliptical. So it's time is difference is it dependent the circularity the your data.
Yeah, sure. But of course, the circularity is not account for the analysis. But I think it's not so important because even though we propensity matching in the annulus area and perimeter, and also the pre-dilatation and post-dilatation, such kind of very anatomical and procedural characteristics, the results are still stabilized in this analysis. So that's the I think the better hemodynamics can be achieved.
okay. It was so important question. Thank you so much. And thank you so much, Masa, for a fantastic presentation. So with Navigator, we really learned a lot from you that we can achieve very good results. Thank you so much for your presentation. And I'd like to hand over to the Maurizio.
Yeah, thank you, Kentaro. Let's move now to another really challenging but quite common situation, which is how to deal with large annuli. And I would like to invite on the podium Virag from Australia to show one case example, and then we will discuss on this topic.
Thank you very much for the faculty. Thanks, Maurizio and Kentaro. These are my conflicts of interest. We'll just start with a simple case, and then we'll hopefully discuss this case. So the patient that I'm sharing with you today is a 73-year-old man who's got symptomatic severe aortic valve stenosis. He's comorbid. He's known ischemic heart disease. Initially first came to our centre with an ST elevation myocardial infarction back in 2016. Developed an ischemic cardiomyopathy and had severe left ventricular impairment, which improved after cardiac resynchronization in 2023. He's also got some mild chronic kidney disease, hypertension and dyslipidemia. Aside from this, he's from home, he mobilises with a stick, and only has very mild frailty. So young, but a little bit comorbid. Transthoracic echocardiography confirmed symptomatic severe aortic valve stenosis, quite heavy burden of calcification in his aortic valve leaflets, and certainly a mean pressure gradient of around 45 millimetres squared with an aortic valve area of around 0.8. This is his TAVI planning CT. Just looking at the video on the left-hand side, you can see there's no real challenges in terms of access. This would be suitable for most valve platforms. The left main coronary hearts were all okay. There is some tortuosity in the iliofemoral system, but nothing prohibitive, and certainly the calcification distribution was reasonable in terms of an access side of things. In terms of the annular size, the annulus was large, with a perimeter of 93, an area of 688 millimetres squared, and it was a relatively horizontal aorta as well, with a 72 degree from the horizon to the annulus. So I might stop there and ask people what they would like to do, or the considerations in this case.
Yeah, thank you so much. So again, a challenging case, not only from anatomical, but also from a clinical standpoint, let's say. And maybe let's start from Rohan. Can you comment a bit on how would you treat or how would you approach this case in your center and in your practice?
Thanks, Maurizio. This is kind of an Australian case, isn't it, Virag? Big gentleman, big annuli. And he does have comorbidity with some left ventricular dysfunction as well. Nothing really precludes either or most of the available TAVI devices. And in our centre, we would be looking at either a balloon expandable or a self-expanding valve. There are a couple of aspects of it that I think are interesting. And first of all, if I was doing a balloon expandable, we would be doing an overfill, which is one thing to consider. The second thing is the horizontality. And I think with the horizontality, you want to have a device where you can have precise placement. So this, we would do this in either way, but if we use a 35 Navitor on occasion for this, and it's a larger prosthesis, but the interplay and the softness of the prosthesis allows for a very good and precise placement in both the non and the left coronary cusp. And with the horizontal aorta, that may be well. The other important thing is that in the context of potential LV dysfunction, you often need very slow, if any, pacing, and the degree of hemodynamic compromise is very limited as well. So I think that that would be a pretty good option. I think that your iliac anatomy looks pretty good as well. So we would predilate to the mean diameter in patients of this nature to try and prevent the need for post-dilatation. I can't really see the calcification, but I'm presuming in the context of the findings on the echo, it certainly looked pretty heavy. So we would give a good pre-dilatation.
Yeah. Many aspects to be considered, many important elements to be considered. I would ask Veeral to move on with his experience with this kind of patient, and then to show us how you treated him, and then we can have final discussion altogether.
Sure, thank you. So, thankfully these days, we're kind of spoilt for choice for treatment of large annuli. And if you look at the available platforms that we certainly have, from the self-expanding valves, Navitor and Evolute, on paper they treat a very similar perimeter and annular profile. And then the balloon expandable valves, slightly smaller area, although obviously most of us are very comfortable going to much larger areas with overfilling. And of course there's the My valve, which comes into a size up to 32, which can treat extremely large annuli as well. It is important to remember that the differences between these valves, and if we look at the difference between the two self-expanding valves, one of the things that stands out is the difference in sheath size. So the 35 millimetre valve goes through the same 15 French inline sheath that the 29 millimetre valve will go through, which does actually cause some problems with the valve, which I'll go through. But really, you can get away with using these really larger valves in quite difficult annulus. So TAVI in Australia, we're a little bit behind what happens in Europe and America, in that we've been a bit slower to uptake and transition into TAVI, but TAVI volumes are increasing exponentially, and we're moving into younger and younger patients. And what that means is that when we increase our numbers and we look at younger patients, we know that in our Australian population, around 15 to 20% of TAVI cases have large annuli. So that is an annulus greater than 630 millimetres squared, or a perimeter greater than 85 millimetres. And so we're treating more and more of these patients. What are the specific issues that come to mind when we're dealing with these patients? Well, they don't just have a large annulus, they've got a large aortic and valvular complex. And what that means is their sinuses are large, often their STJs are large, and they commonly come with horizontal and elongated aortas. The LVOTs can also be large, and so depending on the design of your valve, you might find that if you've got a very large LVOT, there's a tendency for certain valve platforms to dive into the ventricle if the LVOT is very large. And probably the most important thing when coming into implanting these valves, the self-expanding valves in particular, is this issue of parallax. Now, when you're implanting a valve, you want to get it as close to the annular plane as possible. And that's not always completely achievable. In smaller valves, when we put the valve in, ideally what we want to achieve is a nice lined up uniform depth on both the left and the non-side so we don't have any parallax. But that's rarely the case. And in fact, we introduce these little degrees of parallax. Now, if you've got a smaller valve, say you've got a 20 millimeter diameter annulus, and you've got 10 degrees of parallax, then that equates to about a 3.5 millimeter difference for every 10 degrees of parallax that you introduce. When you go to the bigger valves, the 30 millimeter, there's about 5.5 millimeters. So the bigger valves, you can't get away with as much parallax. And the difference in terms of the skirt is not that much. So the smaller valves have a 9 millimeter skirt with the Navitor valve. The larger valves have a slightly bigger 10 millimeter skirt. But that will not account for the difference in parallax that you see between the smaller and larger valves. This probably explains some of what the things we see with the larger annular valves. We do see higher rates of paravalvular leak, higher rates of pacemaker implantation, and certainly a tendency to recapture and reposition a bit more. Why does the Navitor work well for these cases? Well, there are lots of reasons why the Navitor works well. It's an intraannular valve. It treats a very large range, as we've talked about. It's got this really remarkable active sealing cuff that synchronizes to the cardiac cycle. And you can see in the video in the right-hand frame, during diastole and systole, you can see the movement of this cuff to fill in with the system. So it really mitigates paravalvular leak. It's also got the precise depth markers which really help in terms of positioning the valve when you're going through, particularly with these larger valves, which can get quite a bit of parallax. But probably the most important thing and the most beneficial thing is actually the delivery system. Because to reduce the parallax, you need to have flexibility within your delivery system when you're introducing this valve. And I think the FlexNav is the most flexible and deliverable system currently available. And of course, it's got excellent hemodynamics. And we know that it's got low PVL. So for these cases, these challenging cases, yes, you can choose any number of cases, but we find that the Navitor, the larger frame valve, is certainly a very stable and comfortable deployment that gives us some precise positioning. Shall I continue with the case?
Yeah, maybe you can show the outcome of the case and then, yeah.
So with the larger valves, I guess I always predilate the larger valves, kind of irrespective of the amount of calcification. I think it just allows for the uniformity of the device to expand when you deploy these. You can just see this is the 35 millimeter going in and around, being introduced and around the aortic arch. It's very similar and very smooth to introduce. And it is just that 15 French inline sheath that we're going in for. It's important with these that because of the engineering feat of getting the 35 millimeter valve still into that 15 French, it's actually relatively tight, to within that sheath, and it can make it difficult to recapture. So you want to avoid recaptures as much as possible. You definitely want to avoid recapturing above the valve as much as possible. So you want to start perhaps a little deeper than what you would normally start with this valve. Usually start in the the cusp overlap view. We start at somewhere between 3 and 5, and then it's a very slow release. The other thing I tend to do with the 35, which I don't do with other valves, is I generally pace. sorry, with the other sides, they're generally paced. So I pace somewhere between 100 and 120, again, to just make sure everything's nice and stable as we're going up. And it's a very slow deployment and a very slow release, taking as much tension out of the system as you possibly can. And I think if you follow these steps, you can get a very precise and accurate deployment almost every time you deploy the 35mm valve. Recapturing can be tricky. If you do need to recapture, then you may need to use the fine adjustment wheel as well. And again, you want to do this below the level of the annulus as much as possible, just in case you aren't able to completely recapture the valve. That precise deployment allows you to get a really good valve position. You get excellent hemodynamics. It's a very large valve. You're not expecting to see any patient-to-prosthesis mismatch, no aortic regurgitation, and excellent hemodynamics. So I think TAVI in large annuli certainly has some specific challenges. The large aortic valvular complex, the effect of parallax is certainly magnified in these valves. And I think the larger Navitor valve offers a really good solution to some of these problems. Its deliverability, the flexibility of the system allowing you to achieve coaxiality and minimize parallax, and the stable and predictable deployment. I think it makes it really well suited to these large and horizontal annuli. And of course, with all these cases, you know, the most important thing is planning. Thank you.
Thank you so much. Excellent demonstration and excellent outcome. I have a really easy question. How relevant is in your practice to have a large self-expandable platform like Navitor 35, which is at the end so easy to implant? So how many percentage of patients you expect to treat in Australia, for example, with this device?
Yeah, so the large annuli in our population accounts for somewhere between 15 and 20% of the patients we see. So it's actually quite a large patient proportion that we see. And so it is important to, you know, have a valve platform that's going to be able to treat these patients. And prior to the 35 coming out, that was certainly an issue with the Navitor portfolio. But now we see excellent results with these larger annuli.
And then maybe another question. You showed already some tips and tricks that help to make this implantation, I would say, straightforward. It's really straightforward. We are used to difficult implantation in larger self-expandable valve, but this is not the case. May I ask you which is, in your opinion, the big advantage of this valve compared, for example, to 34 Evolut, which is another large device which is eventually possible?
Yeah, so the two biggest differences that I find, one is the flexibility and deliverability. So having the FlexNav sheath allows you to very easily achieve coaxiality as you're deploying the valve. Start a little bit deeper, come up, you can really move the position of the catheter system to neutral. The second thing is, because of the way you're able to preserve hemodynamics during valve deployment, you can really take your time with this valve to get that right and make small adjustments as you're deploying the valve, which means that you get that very precise positioning. It's not all or nothing when you suddenly pick your position, you rapidly pace, and then you deploy most of the valve, and then you reassess your position at that place. Here, you're really assessing your position all the way through. And I think that's where it excels.
And maybe one last comment, maybe from also someone from the panel. What's your initial experience with outcome? I have a really good initial experience with 35. It works really well, no paravalvular leak.
Look, what a fantastic deployment. And I think that the lack of canting, because you're able to precisely, is an important factor. The other factor is it is tighter. You do have to go slower, but you can recapture as long as you maintain, as long as the valve is not completely bent. And so that's certainly possible, and we've done that. But I think that you're able to recapture and capture without going the full way. And I think that's a really important point. And the amount of hemodynamic compromise is quite minimal. And we also pace probably at about maybe 120. you know. And so we find also, I must say, to predilate the mean diameter makes quite a big difference in mitigating PVL.
Thank you. Thanks a lot. And I think Kentaro can introduce now the next topic.
Sure. So I'd like to introduce the last speaker, Dr. Yusuke Kubari. Actually, he used to be our fellow in our Caribbean City Hospital, but nowadays he's a fellow in Copenhagen, Denmark. So please start.
Thank you for your introduction. My name is Yusuke Kubari, interventional cardiologist from Riis Hospital, Copenhagen, Denmark. Today, I'd like to talk about radio TAVI feasibility, how to optimize the index TAVI for future radio TAVI. This is my disclosures. So why do we talk about this topic today? As everyone here knows, the number of younger patients who had a TAVI is already increasing worldwide. And also recently published ESG guideline recommends TAVI in patients older than 70 years old. This is a really big move, and the indication of TAVI is expanding towards the low risk and the younger patients. So redo TAVI is no longer rare. So the lifetime management is very important topic to discuss. So I quickly present a case, and I will share our simulation study. So here we have a 71-year-old gentleman who has a history of hypertension and diabetes. Also, he already had a pacemaker for a complete AV block. His body size was relatively small for Danish people, and he was referred for symptomatic severe aortic stenosis with NYHA class 3. Echo demonstrated a high gradient with slightly reduced ejection fraction with mild AI. Also, he had moderate coronary artery disease, but FFR was negative, so we deferred the PCI, and he also had a good renal function. If you look at the cardiac CT, you can see the slightly elliptic aortic annulus, and the area of the annulus is around 110 millimeter square and perimeter of 81 millimeter, which is equivalent to the perimeter diameter of 26. The size of the LVOT is very similar to the annulus, but slightly bigger than the annulus. The diameter of the sinus bursa is more than 30, and also similarly, the STJ size was around 28, 29 millimeter. You can see that he has a tricuspid aortic valve, and also if you look at the right image, the leaflet was moderately calcified. Both coronaries are high enough for index TAVI. And typically we use the cusp overlap view and the LCC isolation view, but both angle we can easily achieve. And the aortic arch was quite normal. And both iliofemoral arteries are moderately tortuous, but enough caliber with almost no calcification. So how do we treat this patient?
Thank you so much. Thank you so much, Yusuke, for your presentation. So maybe I would like to ask Simon for the short question. So how would you treat this patient in taking into account the lifetime management?
Yes, so I think this is a very important message because for immediate success or results, then every valve can do a good job. But we are looking at lifetime management. This is a relatively young patient and also some coronary artery disease to start with. Then in the future, we need coronary access, future tough in tough or tough in tough. So there are many considerations to make the good decision for the first valve. So I think for this kind of case, I would prefer to avoid too high leaflets, because in the future, the second, third valve may have difficulty. So I would definitely choose an intra-annular valve. Yep. So this would be my first starting point. And secondly would be choose an intra-annular valve with very good hemodynamics, because we know hemodynamics could also translate into durability. Yep. So this is my approach.
Yep. So lifetime management and durability is also quite important. So Yusuke, so please continue your presentation.
Thank you. So when we talk about redo TAVI feasibility, the terminology is complex. So let's get in simple. What will happen after the redo TAVI is the leaflet of the index TAVI, THV, will be pinned up, making a covered stent or tube. We call it nail skirt, which may shut down or compromise the coronary flow. This will be a main issue. And the rest of the index TAVI leaflet, we call it leaflet overhang, which we are not sure yet of its impact on hemodynamics. Technically, we also should know that index TAVI type, implantation depth, and the commissural alignment of index TAVI, and also second valve type, second valve position, all these affect the redo TAVI feasibility. That is why the choice of the index TAVI is very important. So this is a pure CT-based simulation of redo TAVI feasibility. We have analyzed 100 post-Navitor CT from 2 centers. One is from Denmark and one is from USA. And we analyzed the redo TAVI feasibility. I don't explain too much about the methodology, but if the nail scut is below the coronary, we call it green or low risk for redo TAVI. On the other hand, nail scut is above the coronary, then we measure the VTA, STJ, and VTC. And based on these measurements, we categorize into, again, green, low risk, no concern, no care, or orange, intermediate, or red, high risk for redo TAVI. So this is the result. When we put the SAPIEN in a low position, no patient is a high risk for redo TAVI. On the other hand, when we put the SAPIEN in a high position, 1/3 of the patient is a high risk for redo TAVI. When we will look into more details, regardless of the index Navitor implantation depth, when we put the SAPIEN in a low position, again, no patient is a high risk for redo TAVI. On the other hand, when we put the SAPIEN in a high position, redo TAVI feasibility is completely depends on the index Navitor implantation depth. Interestingly, if you compare these results with other self-expanding valves, of course, we cannot use the accurate anymore. Regardless of the implantation depth of second SAPIEN, Navitor offers a promising result, which this is maybe because of the interleaflet position of the Navitor. So redo TAVI feasibility can be modified by the index TAVI type and the TAVI implantation depth. So that is why it is very important to choose the right index TAVI with the right implantation depth, considering the lifetime management of patients. And finally, what should we do for 37% of patients who are unfeasible of redo TAVI? We can do the change. We can change the implantation depth of second TAVI, or we can do a leaflet modification like a basilica or unicorn. And for effective leaflet modification, we know that the commissural alignment is very important, and we are investigating the impact of commissural alignment on the redo TAVI feasibility. Thank you.
So thank you very much, Yusuke, for your fantastic presentation. I'd like that question to Yohei. So you're quite specialist in the not only TAVI but also for the ICE-guided implantation. How would you optimize the incidence of the pacemaker implantation, and how would you optimize the future TAVI and TAV procedure?
Thank you, Kentaro, and great presentation, Yusuke. So actually, as he emphasized, I think the appropriate depth of the index procedure is very crucial when we achieve coronary access, of course, and for the future redo TAVI. So I think if the hemodynamic is not compromised, I always try to go slightly, deeper, but still not having a conduction disturbance. Of course, it depends on the patient's age and the underlying conduction disturbance, so on. But I think, as Yusuke emphasized in this study, I think nowadays we don't go just too high, too shallow implantation to consider the future redo TAVI.
Yep. By using ICE catheter, you minimize the risk of the pacemaker implantation. You also maximize the possibility for the TAV in that procedure.
Exactly.
So I would like to ask a question to Rohan. So what do you think of the impact of the leaflet overhanging in TAV procedure?
Thanks, Kentaro. And in the couple of cases that we've had, it's important to understand what the mechanism of the valve failure is. And in some instances, it's actually a frozen leaflet. And I don't think we have all the data that we want, but we want to avoid it as much as possible. And it really comes down to balancing the height of your balloon expandable implant versus coronary risk plane versus overhang. And I think if you've got an intra-annular valve as the first prosthesis with a shortish skirt which allows an optimal deployment which is not screamingly high, but still allows depth and coronary access. It allows the best of both worlds.
Yep.
Yeah.
Great, thanks. So Yusuke, you have the one more closing discussion, right? Yep.
So we decided to do the Navitor Vision 29. So here's the plan. Transfemoral TAVI in a pure local anesthesia and the main access from the right side pre-closed with one prostyle. And we typically use a big sheath, 20 French dry sheaths, and pre-dilatation with a 23 non-compliant balloon. And we deployed the Navitor Vision 29. The procedure was very straightforward, so I don't explain too much. Just we started from the cusp overlap view, and if we are happy, then go to the LCC isolation view, and then we deployed. So this is the last result, in the good implantation depth, and also no PBL, you can see that, and we close the groin successfully. So this is the echo the day after. The single-digit mean gradient and already improved ejection fraction and with no PVL, and the patient going home next day without any complications. So if you look at the post-TAVI CT, you can see the well-expanded Navitor stent frame. Also, the left coronary alignment is good. And if you look at the commissural post-coronaries, if you look at the right side, upper left side, dark green panel, the commissural post is always below the coronary. That means the nail scout is always below the coronaries, and the redo TAVI risk is very low, no matter what valve we choose. Also, again, you can see the very expanded Navitor valve. So, of course, at the annulus or inflow level, you can see the elliptic stent frame, but also the native annulus is also elliptic, so that I think that this is how it is. So this is my conclusion. The selection of the index TAVI type is essential for the lifetime management, and Navitor Vision is among the most promising TAVI platform from the perspective of redo TAVI feasibility. The impact of commissural alignment on redo TAVI should be further investigated in the future study. Thank you so much.
So congratulations, Yusuke. You optimized the implantation depth to maximize the chance for the TAVI procedure in the future. So we have some questions from the audience. I would like to ask Johan to take this question. So do you adjust your implantation angle to avoid implantation with parallax? How would you adjust your implantation angle of Navitor? Sometimes it's the vertical, it's sometimes the horizontal. Do you have any tips and tricks?
No, that's just conventionally.
Okay.
So
Sure.
no tips. So
Yusuke, you demonstrated the distal opening technique, and you also adjust the axis of the Navitor. Could you please share your tips and tricks? How do you optimize the implantation angle of the Navitor device?
Implantation angle over the, the seat.
You mean the horizontal or vertical?
So thank you for a question. So usually the Navitor the delivery system is very flex, so it tend to go to the outer curve. That means that it's good for horizontal case. But if the patient has a very vertical arch, then as you mentioned, that we sometimes take a distal opening technique. I forget the new term, but we open in the ventricle, and then after opening, we pull. Then also the delivery system is going to the more inner curve and also, I'd say, steep. Then we can adjust the alignment.
Yeah. Usually the Navitor is quite flexible, where it tends to lay down, but we need to pull back the device. but sometimes we need to lay down the device. In case of that, so we need to push the wire. We also push the device if we lay down the device. And one more question. So how would you avoid the upward motion of the device?
Thank you. So I think, I think we need a good control pacing to stabilize the delivery system. That is the most important thing.
And the slow implantation is also...
Yeah, we typically go slow, and after the opening, then we go fast.
Yep. Do you have any comment?
Kentaro, just one of the aspects, it's either going to be low on the left coronary or high on the left coronary.
Yep.
And you very elegantly do a low opening. We sometimes do just go to 20 or 30% and then go to the L. And when you go to the LAO, you'll have a good idea of where your left coronary is going to lie. And at that stage, you can actually pull back slightly and you'll realign. You'll realign it, which will then allow it. One of the aspects about avoiding the pop-up is, I think, to be really sure that you don't have any non-uniform stent expansion. I know they're different terms, because that potentially can allow for it to move upwards as well. And I think that pre-dilating to the mean diameter is a really good way of sort of solving that. But we tend to move between the LAO and the RAO and give it some time to warm up before we do that. And if we do see it, often a partial recapture and reopening can sort that out without post-dilatation.
Very important tips and tricks.
Yeah, I think what Rohan mentioned is very important. We should avoid under expansion. So when we started this platform, using this platform, we used short pre-dilatation size based on the shorter diameter, but now we shift towards the mean diameter or perimeter-derived diameter. And the incidence of incomplete stent opening has dramatically decreased. And now we can aim quite accurate positioning of the valve.
Thank you. I think it's time to wrap up. I would like to just summarize a bit what we have been exploring and discussing during this session. We have seen some challenging anatomical scenarios. First of all, small annuli and then big annuli. And in both these scenarios, Navitor performed pretty much well, especially in terms of hemodynamic in small annuli and in terms of easiness to implantation and the predictability of the result in large annuli, which could be a challenging situation. And then last but not least, we have been discussing lifetime management. And I think it's pretty much important to say that from our discussion came out that Navitor represents, I would say, an ideal choice for a young patient with many years to live, because it represents an excellent index TAVI, also in small and large anatomy, easy access to the coronary, and then it allows easy refeasibility of TAVI in the future. So we do not compromise the index procedure, and we have an easy procedure in case that is going to be needed. And with that word, I would like to thank Kentaro for co-moderating this session and all the panel, and of course all the participants for staying with us until the end. And I wish you a great prosecution of the meeting. Thank you.